Welcome to the Alzheimer's Disease Virtual Education Summit Series, presented by Albert Einstein College of Medicine of Yeshiva University at NeuroSeries Live. You are tuned into the live session of Biomarkers and Imaging, Emerging Strategies for Diagnosing and Monitoring Patients with Alzheimer's Disease, with Dr. Joy Snyder. My name is Dr. Ann Fagan, and I am a research professor of neurology at Washington University School of Medicine and a faculty member of the Hope Center for Neurological Disorders. Today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime during the program through the box in the lower left-hand side of your screen. Now I'd like to introduce Dr. Joy Snyder, Associate Professor in the Department of Neurology at Washington University School of Medicine. Her clinical interests are in the diagnosis and treatment of patients with dementing disorders. She sees patients at the Memory Diagnostic Center and participates in research studies at the Washington University Alzheimer's Disease Research Center Memory and Aging Project. Welcome, Dr. Snyder.
Thanks, Ann, and good morning, everyone. This morning, we're going to be talking about biomarkers and imaging and their role in diagnosing and monitoring patients with Alzheimer's disease. This is an outline of what we're going to talk about, and the first topic is why should you care about diagnostic testing for dementia and Alzheimer's disease? I assume you care a little bit because you're tuning in this morning, but we're going to go through the reasons why this is going to be something that will be very important for all of us, whether in neurology, primary care, or whatever your practice setting. To start off with, this is a very old slide, but still makes a wonderful point, and that is Alzheimer's disease is an age-related illness. It's quite uncommon in people below the age of 65, but each decade after 65, the incidence doubles, such that in the 85-plus group, shown in the gray bar on the far right, the prevalence of Alzheimer's disease is between 40 and 50%. So at age 85 and above, almost half of people may have Alzheimer's disease. This is pretty impressive, but when you superimpose this on the demographics of our society, which is changing both here in the US and worldwide, you begin to get a picture of an increasing number of people with Alzheimer's disease. So this is a demographic slide, and what it shows you is with women on the right and men on the left, the number of people in each age group, going from the youngest on the bottom up to the over 100 group on the top. And as you can see, in 1990, there weren't very many people over 100, and you can see the baby boom generation there in their 20s to 40s. We flash forward to 2010 and then 2030 and 2050, you can see that the baby boomers have aged, people are living longer, so the number of people in those older age groups is increasing dramatically. One of the fastest growing groups, of course, is 85 plus and even 100 plus. When you add those two things together, what you get is a lot more Alzheimer's disease. So for example, in the year 2000 in the US, there were about 4.5 million people with Alzheimer's disease, and you can see the majority of them were in that age group of about 75 to 84 years. By 2030, there'll be 7.7 million, and by 2050, over 13 million people in the US with Alzheimer's disease, and more of them will be older. Another way to look at it is shown here from a slide by the Alzheimer's Association. The number will increase by 2050, and not only will they be older, but a large proportion will have more severe forms of disease. So this is a coming epidemic in the US and actually worldwide. This all comes at a cost, and this again from the Alzheimer's Association shows you the cost of Alzheimer's disease over time, the cost of care for people with Alzheimer's. This is Medicare costs, caregiving costs, medications, et cetera. And by 2050, it's a cool $1 trillion. So this is going to be a major expense in our public health care system. So hopefully you're impressed enough to care about Alzheimer's disease and to be concerned about how we can diagnose and treat it now and how we can reduce the number of people with it in the future. I'd next like to go into how we define Alzheimer's disease. What is it? So Alzheimer's disease was first described in 1906 by Dr. Alzheimer. The disease bears his name, and his first patient was a 51-year-old lady who had the pre-senile or early onset form of the disease. And she presented with rather bizarre behaviors, paranoia, suspicion, as well as short-term memory loss, and died 5 years after diagnosis. What made this unique was that some new staining techniques had been developed, and Dr. Alzheimer was able to look at her brain and characterize the pathology. And what he saw was neurofibrillary tangles as well as plaques. So this is the pathology that defines Alzheimer's disease. Flashing forward now to 2013, these are people that have Alzheimer's disease. You may recognize some of them. Our former president, President Reagan. If you're a blues fan, there's Etta James, Charlton Heston, Rita Hayworth, Scotty for you Star Trek fans, and Sugar Ray Robinson. So Alzheimer's disease strikes all demographics, all groups, both genders. The way we think of it is a progressive loss of memory and thinking abilities. The earliest signs include loss of poor recent memory, forgetting appointments, being repetitious, then trouble with getting lost, balancing the checkbook, other activities of daily living. This is what characterizes Alzheimer's disease. It's not yet a dementia at these mild stages, so some people call the mildest stages mild cognitive impairment rather than dementia. How do we diagnose dementia? And you might have heard some of this in the past hour's presentation. The diagnosis depends upon a clinical assessment, largely getting a history from the patient and someone who knows them well as some objective tests of cognition. We do some laboratory studies, mostly to rule out treatable causes of dementia. Serum chemistries, liver function, thyroid function, B12, those are all pretty routine. What's new and what we're going to focus on today are some disease-specific biomarkers. And I'm going to cut to the chase. This is the bottom line and the underlying message of the biomarker studies, is that biomarkers can detect underlying brain amyloid pathology. And they do this with a high degree of sensitivity and specificity. But they don't tell you whether that pathology is causing the cognitive symptoms. So they're very good at detecting pathology, but it gets a little more complicated after that. So that's the key message. So a new view of Alzheimer's disease, and this is a slide from my colleague at the Knight ADRC, Dr. John Morris, and we're starting to think about Alzheimer's disease in different ways. And this will be very important as we go further into the biomarkers. So Alzheimer's disease is a term that we propose we should use to refer to the neurodegenerative brain disorder, to the brain changes, the pathology, regardless of the clinical status of the person. And the other key feature is that it's a continuous process. A person doesn't wake up one morning and suddenly have dementia. It's a very slow process that evolves over time. You can divide this disease into two major stages. The first one is preclinical, where in fact there are no symptoms. We can't detect any changes in memory and thinking. And the second part is the symptomatic or clinical stage, where we begin to detect first mild and then more severe changes in memory and thinking. You can further divide the symptomatic stage into a couple of stages. And one important thing to say about the symptomatic stage is that it's a decline in an individual person's performance. So we often define it by comparing people to age-matched norms, but what's really important is how a person changes compared to their baseline. And these changes can go from subtle to very severe, eventually interfering with daily function. We call the mildest stage of this incipient, prodromal, or mild cognitive impairment. And then when they reach a point where the deficits interfere clearly with their daily function, that's called a dementia. So this is what the brain looks like in Alzheimer's disease, and many of you have seen this before. The one on the left is a normal brain, has lots of brain substance, and the one on the right, the brain is shrunk and you see more fluid. The gyri are much clearer because they've shrunken. This is how it looks pathologically. If you look with an MRI scan, similar picture. Again, on the left-hand side, you see a normal brain with nice, robust gyri. On the right, the brain is shrunken, and you can particularly see shrinking in the areas pointed out by the arrows on the left in the hippocampus and entorhinal cortex. So this is what Alzheimer's disease looks like in the brain. If we look a little deeper, and this is a cartoon of the pathology, what we see is the two major pathologies that were described by Dr. Alzheimer. So inside the neurons, inside the brain cells, we see tangles, which are made of hyperphosphatemia